Okay. All right, so we can get started. My name is Haley Troy, and I'm a research coordinator here at the Center for mHealth and Social Media. I am honored today to introduce Dr. Abiodun Atoloye. Dr. Atoloye holds a PhD in nutrition science from Utah State University, and she currently works as a postdoc here at UConn. Her research focuses on addressing nutrition disparities through improved access to affordable and nutritious food. She explores the determinants of and solutions to poor nutrition and health outcomes using a mixed method research approach, as well as geo-narratives and innovative measurement tools. Today, Dr. Atoloye will provide an overview of refugees' nutrition and health before and after resettling in their host countries. He will share evidence-based practices for success in nutrition education among refugees, plus lessons learned in community-engaged research in the U.S. Thank you for joining us today. I will now turn things over to Dr. Atoloye.
Good morning, everyone, or afternoon. And thanks, Ellie, for that beautiful introduction. I would like to say thank you to Dr. Sherry Poggetto for giving me the opportunity to present my research on refugees on this platform this morning. I'm going to talk a little bit about my background. So I came into the United States in 2015 voluntarily to pursue a PhD degree in nutrition science, which I completed at the Utah State University. And so I came into this research in the year 2019. That was about the last semester as a PhD student in Utah State. So upon transitioning to my current position at UConn, I continued to work with the research team on the refugees research. And so I can say that this topic is particularly personal to me as a voluntary immigrant in the United States. So my presentation objective today is to describe refugees' nutrition and health before and after resettling in their host country. I'm also going to share some evidence-based practices around nutrition education among refugees, and also share some lessons learned by my research team and I on a community engagement research conducted among refugees at Utah State. So refugees, they are part of the big group of immigrants. However, they differ slightly from other immigrants who came voluntarily to their host country. So by definition, refugees are a group of people that are forcefully displaced from their home due to conflict, war, or persecution, among other reasons, and they are unlikely to return to their host country. And so the United States is one of the countries that settles a large percentage of refugees. By the US law, refugees, they are defined by immigrants who have demonstrated that they have been persecuted and they have reasons, or they have reasons to fear persecution. And they are admitted into the United States based on one of the protected grounds, which includes race, religion, nationality, their political opinion, or they being a member of a particular social group. I'm going to talk a little bit about refugees in the United States. And here is a figure showing how the number of admittance of refugees over the past decades sort of fluctuates. And we could see that around the year 2020, there is a deep decline in the admittance. And in the more recent years, there is a gap between the cap, which means like the standard number of people that are speculated in the fiscal year to be admitted into the United States and the number of those that are actually admitted. So we do see a gap between these two variables in the recent years. Also, there is a variation in the geographical origin or the nationality of refugees that are being settled in the United States across the different states. A closer look at this map is showing that a larger percentage of the states in the United States are settling refugees from countries like Yemen, which is followed by refugees from countries like Cuba, then followed by the demographic, the demographic Republic of Congo, and also the Somali. In the literature, there is a strong evidence of the term healthy immigrant effect, which is a condition where when refugees enter into their host country, they come in an healthy state of health, and as the year goes by, their health situation gets worsened, as seen in the figure on the left-hand side, where the diabetic prevalence among refugees sort of like increases over the years up to where they have the level of the same prevalence compared to the US-born individuals. And also, a previous studies has looked at the differences in health outcomes between refugees and immigrants and the native of a country. And there is a strong association between the prevalence of health outcomes and the number of years. And the difference is strongly seen among refugees and immigrants compared to those in the country who are natives. However, there isn't any difference between the refugees' health outcomes and immigrants. Refugees and immigrants sort of face some similar challenges. However, they're slightly different in some experiences and challenges that refugees experience. And these can be tied to their experience with fleeing devastating situation from their host country, and they sort of come into the new or the host country with some of this burden, and also struggle to meet some of the needs or struggle with some challenges in their new country. So I'm going to talk a little bit about some of the food and health-related challenges that refugees face. So between the period of conflict in their home country and when the forced migration occurs, there is exposure to hunger and nutritional deprivation. And it might also extend to lack of water or water contamination, inadequate living condition, and lack of basic medical resources, which might also increase their risks to poor health conditions. And during resettlement, refugees, they come into the resettled or the host country with an already compromised health condition. And in addition to that, they are faced with other challenges, which include struggling to adapt to the new food environment. Oftentimes, back in their home country, they might be exposed to informal food landscape, and they might struggle to adapt to the formal setting in the new environment. There is also an issue related to the dietary acculturation, where the the incoming refugees take up dietary practice of the home country, of the host country. And also in the literature, we did see that there is limitation to access to the cultural food, which might often be expensive, and they do not really have like some of the resources to acquire this cultural food. We also see limited access to public transportation, issues like language barriers, which exacerbate their food insecurity experience and increase their risks to poor health outcomes. In the midst of these different challenges, refugees, they possess many cultural food practices that are already in support of good health. An example would be like the diet quality of this population as seen in this map. Burma, they have from the Yemen country. And we did see here that they have a lower calorie meal of food compared to those from the United States. And it's naturally or traditionally low in sugar, oil, and meat. And about 50% of their diet is also from cereal and greens, which also include all grains. In addition to this, there is also like a strong experience with cooking from scratch and gardening among refugees. They already have a great habit of eating together as a family, and they have a strong social support within their ethnic community, which make them a good target for messaging to address nutrition needs among them. And so in this project, we leverage on the collaborative or partnership model in addressing needs among our target audience by collaborating with existing ethnical community-based organization in the target community, and also working with the SNEPED and HEFNEP coordinator, including the nutrition educators and paraprofessionals in nutrition. And so we also worked on different approach to establish the different components that went into the nutrition education by first identifying some evidence-based practices that has contributed to the success of nutrition education programs in different countries and also in different communities. So the first approach includes the nutrition education provider survey that we conducted, which was a survey among SNEPED and FNEP directors across the United States. So we were interested in capturing their ideas about factors that contribute to the success of the nutrition education programs that they deliver to their own audience. And then we moved on to do a scoping review of the literature to identify some of the strategies that have been used in delivering a successful nutrition education among refugees, not limited to the United States, but also across countries across the Western region. And we also incorporated a refugees interview component, and that was set in place for us to understand the perception of refugees about the ideal, or I would say a culturally acceptable nutrition intervention that they desire to be implemented in their own community. And so here are some of the common themes that we found from the nutrition education provider survey, which include participatory learning and hands-on activities. We did see that approaches such as cooking demonstration, gardening, food taste, and store tour of visit were some of the participatory activities incorporated into some of the existing nutrition education among the refugees. And also, importantly, is the recognition of the asset that refugee has in terms of elevating their values and assumption in the programming. And we also saw a great collaboration between the nutrition education providers and also the community members. So the nutrition education providers incorporated many attempts to get the community members involved in the design of their programs in terms of the evaluation, questions that should go into the evaluation, or even the components of the nutrition education delivery itself. And from the scoping review, we saw an outline of the process that are involved in conducting a successful nutrition education among this audience, one which include the need assessment. So a couple of studies were looking at they did use survey to identify needs among the target audience, and also collaboration among the community members and refugees were also one of the themes that came up. And next is the client-tailored approach, which focuses on the specific needs of the target audience. And we saw that many of the studies were looking at like the health status of the refugees themselves, the literacy level, tailoring the content of the nutrition education to meet the English proficiency level or even the mental status. One of the studies that we came across in the scoping review actually decided to create an environment that is safe for the refugees to be able to pay attention during the delivery of nutrition education. And also we saw the participatory and hands-on activity coming up in the scoping review as well. And a component of educators training was also included in a few of the study, and they incorporated approaches or topics that ranges from the motivational interviewing, the community-based participatory approach, and intervention delivery principles. And so for the refugees interviews that we conducted, we did see that there was a high receptiveness for nutrition education among the refugees. They were already prime to receive the nutrition education. And also, there was high consensus about them having a community member to lead the nutrition education program. And also, there was also a preference for group education settings. We did see that the group that we wanted to implement the nutrition education among, they were willing to move out and be involved in group activities, learn from other people, and specifically, they were interested in teaching other people about their own traditional diet, like recipe sharing. And so for the community-based nutrition education that was developed, we sort of work across the different teams that were identified via the provider survey, the scoping review, and the needs assessment that was already conducted through the refugees interview. So we had the need assessment component to guide our interventions, and also we put in place their request for the community member-led approach. We also incorporated the participatory learning approach, where we had like food demos and farmers market tour. We also tailored the intervention to meet the different needs of the participants. And so the target was the Utah State, where we recruited refugees from the Somali Community Service of Utah. And this is an ethnic community-based organization that are already in the community, helping to address needs among the Somali refugees, ranging from providing direct services and support for employment and vocational learning, as well as helping them of providing support for English as a second language. And so we recruited about 45 participants into different sites, and they include refugees who are older than 18 years and up to 58 years, and they must have lived or resettled in the United States within the last 5 years. And so some of the uniqueness of the program delivered include the adaptation of an existing SNPED curriculum, which is a curriculum that has been tailored to meet the needs of the low literacy and low-income population already. And so for this program, we sort of adapted it to meet the needs of the Somali refugees by incorporating or pulling out the barriers to language, one, and to also meet their literacy need. And so we also included the community-led approach, where one of the researchers delivered the intervention in the local language. So she was part of the team member of the research team, and she had she's Somali and fluent in the language. And at the beginning of this research, we intend to deliver the research in a face-to-face approach. But then COVID hit, and there was another adaptation to the program where we had to incorporate it in a Zoom or a virtually delivered approach. And so the researcher helped in modifying the program so that it is delivered at a low literacy for the refugees. And one good thing about the way the program was being adapted is because our participants were already in the English as second language program, and the community, the ethnic community-based organization already provided them with tablets which they could use to connect for the program. And the food demo was incorporated where the nutrition educator, that is the PhD student, would have created or prepared the meal and show them the final output of the meal. And during the class, she sort of showed them the different steps to the end product. And then she really had to encourage them to practice. And so within the evaluation for each of the lessons, we sort of incorporated a more an informal mode of evaluation where she would encourage them to practice, and in the next lesson follow up on who did and ask them to share what they did and the lessons that they've learned. So the nutrition education ran for about 12 weeks, and we had like 10 lessons, which was adapted from the Create Better Health curriculum of the Utah SNPED. And it has like topics ranging from the introduction to my plate up to the food dollar, teaching them how to expand their SNPED benefit. And in addition to this, we incorporated an in-person wrap-up party where we had like a certification, sort of like a celebration of the completion of the program, and listen to lesson learned or testimonies from the participants, and also distributed certificates of participation. And so these are pictures of some of the adaptation made to the existing Create Better Health curriculum. Here you see that different food that are sort of like tied to the cultural value of the Somali. So in Somali, sorghum is like a typical or staple food. And the first two images on the top is highlighting how the sorghum was adapted to make a traditional bread, which is created by combining the sorghum flour and the wheat flour. And you see the first one showing how the anjero, which is the Somali traditional bread made from the mix of the sorghum flour, being made into a meal that has like vegetable. Another adaptation is the egg in basket, where the anjero was made in that form. And also there is also the sorghum-based salad, where the whole grain of the sorghum was incorporated into other vegetable components to provide like a healthier meal options. And the highlight of these pilot tests included the farmers market store, where our nutrition educator took the refugees to a nearby one of the farmers market within the community. And this farmers market is serving the needs of the refugees in that it incorporates some traditional vegetables that are tied to their tradition. So this store was incorporated to sort of help them to know how to use their SNAP benefit and acquire the extra dollars from the double of food box, so they have more fruit and vegetables for consumption. And so this is also where we had the wrap-up party, and our educator, the star educator, is the person at the center there. You see the certificate being issued out to our participants. And this form of celebration help to incorporate the desire for a community or group setting approach in the delivery of the community-based nutrition education as requested from the refugees themselves during our survey. And so in terms of results, we did see about 80% completion rate, meaning those who started at the beginning and those who ended. So at the beginning, we had about 45 and 36 were able to complete the nutrition education. So in terms of changes in diet and nutrition related outcomes, we did see that at the exit, about 83% of the refugees or our respondents were able to meet the 2 to 3 fruit intake recommended by the dietary guideline, as compared to the 31% that started at the beginning. Similarly, we did see about 8% 8% of the people meeting the recommendation for vegetables at the end of the interventions compared to 0 at the beginning. And in terms of exercise, we did see about 60%, 6% of the participants were able to meet the 30 minutes per day recommendation of exercise, which is impressive. And in terms of other nutrition education, nutrition-related outcomes, food resource management, there were about 10 items that we use in evaluating this outcome. And so 52% of the participants were able to meet or improve 7 out of 10 items. And for food safety practices, about half of them were able to improve in 2 of the 4 items that was used to evaluate the food safety practice. And we did see about 8% increase in food security. And here are some testimonies from the participants during the wrap-up party. We did hear them talk about how they were able to improve their dietary intake, and which also translates to a positive impact on their weight. You see, before I was 280 pounds, now I am 258 pounds. Also, there is a testimony about one of the participants who is a diabetic patient and had high blood sugar and blood pressure. And upon visiting her doctor, there was an improvement in her blood pressure, such that the doctor was asking what she did to get to that state. And so that is just like a positive testimony from the interventions being delivered. Now, I'm going to talk about some of the lessons that we learned as team members. It was great that we did have partners and researchers who are passionate about working with refugees. So the researchers, they were willing to step back out of their, what I will call, expert understanding of nutrition issue to accommodate the community or the refugees' own expert in delivering the nutrition education. And we also were able to incorporate some cultural responsiveness to the needs of the refugees. We were able to respond to some of their requests in the design of the nutrition education program, and this include incorporating the community-led approach, and also a component of them having like a um, group setting included in the intervention. And there was also accommodation from different cultural values in terms of the different food that were incorporated in the model or the demonstration that was included. Another thing is about us being able to leverage on some of the ongoing programs in the community. An example would be the SNEPED program, using existing curriculum within this larger program, and to also bring in the ethnic community-based organization, leveraging on some of the services that are already rendered to the refugees community, which was a great support for us. And at the time when COVID hit, that we had to switch to the virtual delivery, and given that these refugees, they already had access to laptops and iPads, it helps us to be able to make this transition to the virtual delivery of the nutrition education. And last is the component where we were able to build trust among the target refugee community. So at the beginning, we were able to start by explaining the purpose of the research to the Utah to the larger youth, the larger refugees organization that is addressing the needs of refugees, the wider audience of the refugees. Then by the time we were willing to focus on the Somali refugees, they already understand what we wanted to do. And next is that we engage these different trusted community members in the ethnic community organization that I mentioned, and also bringing in a community member as a active participant or researcher in the whole process. And another thing we did was to compensate active participation of our participants in the intervention via the certification issued. We also had some souvenirs given out during each of the lessons by their participation. Where if they are active, they get some compensation for their activeness. And moving forward, one of the outputs from this research was this paper that talked about some of the cultural consideration that need to be set in place when addressing needs among these low resource and diverse audience and low English proficient audience as well. And there are really other research out there that also speaks to the cultural consideration among refugees in terms of their health and also nutrition education. And I would like to say a big thank you to acknowledge my team members and person of the PIs and co-PIs on this grant. And I would like to give a big shout out to Adiba Noor, who was at the center of the whole process. She is the she is a person who worked closely with a community member and did the intervention. And also other entities like the SNEPED and FNEPED director at Utah State University, and the ethnic community-based organization, the Utah Refugees Education and Training Center, as well as the Somali Community Service of Utah. And so I've come to the end of my presentation, and how I'm happy to answer the questions that you have for me. I'm going to stop sharing this slide.
Thank you so much, Dr. Atoloye, for providing such a comprehensive overview of your work with refugees and nutrition and health. Everyone, feel free to put any questions in the chat, and I can help relay those to Dr. Atoloye so we can continue the conversation. Actually, I have a question for you, Dr. Atoloye. You mentioned that you adapted the intervention from the existing Utah SNAP Ed curriculum for nutrition education in Somali via Zoom, in part because of COVID. I'm wondering how you might have seen like a difference or some change in the intervention or the outcomes had this been an in-person intervention.
Oh, good question. So I do not really think there would be a difference in the outcome, because the messages, the key messages in the curriculum will be similar. It's just the method or the approach of delivery. And yeah, so there wouldn't have been any change or difference in the outcome. We might still see the similar, or I would say greater improvement with a face-to-face, because at that point we would be able to incorporate a lot of like more nuanced hands-on activities compared to just like the food demo that we did via the virtual.
Okay, thank you.
Abby, can I add to that a little bit? Can you hear me?
Oh yes, Martha.
This is Martha in Utah. And Habiba may want to add to this too, but that was I thought, a really interesting real world aspect of the study, because I mean, no one could have predicted what we would have been, dealing with, what everyone was dealing with. But what was really interesting to me, and we have asked some questions about that maybe Habiba can give some, just a little bit more if she has any comments on that. But we actually found that doing some web-based was probably a good way to reach people because of some of the transportation issues. They were able to participate in their homes. So I really think finding the right balance of in-person and online might be the kind of sweet spot. And again, I'd love Habiba to add to this, because the participants were really anxious to get together, but to kind of keep the fidelity of it being an online intervention. Since we started that way, we did deliver the whole thing online, but we did get people together at the end to celebrate. But I mean, I'm a huge advocate of in-person, hands-on, but this work, both with doing the interviews and the study, made me rethink that a little bit, because of just those other issues that you can decrease some of the barriers by, and everyone has a smartphone, so, and people are pretty comfortable with that technology. So it was, sorry, I've talked too long, but I don't know if Habiba wants to answer that, but that, that was nothing that we set out to look at, but became a really interesting aspect of the study and intervention.
Yeah, thanks for adding that, Martha. Habiba, you can go ahead.
Okay. Thank you for all and giving me this opportunity. It's a little bit both. So what we see through Zoom, the expectation was way more than what we were expecting. So at the beginning, there was a little challenge how to access and all that. All of a sudden, all they have, as Martha said, is smartphones, and they having some challenges how to use it. Just so that was the beginning. So what we see is like a big improvement in terms of the through Zoom. And some of the findings we found is like which one you prefer, in person or in physical. Refugee family size is more than 7, most of them. They have a lot of children. There is a lot of outcome saying like, yes, we prefer Zoom because I'm not worrying transportation, I'm not worrying my kids, I'm home, I'm learning. So we see that. And we see some saying like, I need to get out because I want to take break from the kids. So I will say it was good improvement using the technology, and it gives a lot of variety. So though some of them still missing physical, like hands-on through instead of Zoom to do it. So it was really, really big improvement. And still we analyzing the data. So hopefully we will share you in the future exactly the numbers, how many say they prefer physical, how many say that. So thank you.
Great, thank you so much. I'm seeing a couple other questions in the chat.
Okay.
So, did you notice or did the participants mention any effects this intervention had on their children?
Yeah, Abiba would be in the position to answer that because she was right on the ground. Habiba, are you still there? Did you
I'm
hear
here.
the question? Yeah. Was there any testimony around the impact of the intervention on the children?
Give me 1 second. I'm moving
Okay.
to another spot.
Oh, okay.
Can you ask me the question?
Yeah, so it's about the impact of the intervention on the children. Was there any testimony?
Sorry, I have to move the room. Now I can. Sorry for the interruption. I can hear you now.
Okay,
Can
so
you repeat your question?
the question is about the impact of the intervention on the children. So was there any testimony around that?
Actually, this was for parents and we didn't go with the children, but we are planning in the summer that we have to have children programs like with the family with their children. So this one was unique only for the adults. So I don't have a testimony to share with you, the children. Besides what the parents say about their intake and what the children prefer, the food they're eating, and how they like to accommodate their kids to eat more American foods, and they want to learn how to cook pizza or American foods. Yes.
Thank you.
Great, thank you. Another question, do you have any advice for how to involve interpreter services or equivalents in resource-limited budgets in this line of research?
Thank you for that question. So I know that based on this, in some of the findings from our scoping review, the use of interpreter is one of the approach in addressing the language barrier. So yeah, it could be a good approach. However, the inclusion of an interpreter needs to be look at, I mean, needed to be looked at holistically in terms of there could be some sort of bias in when interpreting, and that needs to be put into consideration too. So in a limited resource, there are really other ways that we did identify, like maybe using very low literate approach, like maybe pictures that wouldn't need a strong English word for the individual or the refugees themselves to interpret. And that would also take me to talk a little bit about some of the other barriers that are tied to the evaluation of the intervention itself in terms of what method to use in evaluating. Yeah, so we did come across some studies that did use like oral matching instead of like a virtual, a real evaluation form that needs to be filled. So yeah, there are really different ways to like adapt whether evaluation process or tools to this community. And so when dealing with this population, it is important to think of adapting to meet the specific cultural needs and the specific audience. So yeah, and recommending flexibility model in the approach would be the great way.
Great, thank you. Just checking the chat real quick to see what we have here. Can you recap what the findings were from the needs assessment and maybe highlight any unexpected results?
From the needs assessment, so I already highlighted their need to like want a community member to lead. Then we did find like there was a mix in terms of what they really want to learn. While some were willing to like learn from other people or their co-participants in terms of their other healthy traditional food, there are some that want to learn about like the Western diet too, because for the most part, those individuals will be parents with children whose children have been exposed to the Western diet at school, so the parent wants him to like be able to satisfy or address the children cravings for those type of food. So I would say those are like some of the mixes in the findings from the survey among the refugees themselves. I don't know if Abiba would want to add to that. Okay.
Great. I think we might have time for one more question. I'm seeing Michael Puglisi. Would you like to hop in on question?
Sure, that'd be great if that's all right. So I was really excited that you incorporated FNEP and SNAP-Ed. FNEP isn't bad, as badly needs culture adaptation of the curricula that are utilized. There's two main ones you probably know about, Eating Smart and Being Active from Colorado, something like 41 states use. So I feel like it's a little less flexible. I was wondering if you're able to work with FNEP and what that experience was like, because NIFA, who we report to, seemed to be pretty adamant to follow one of those two main curricula that we have.
Yeah, so on the team, we did have like an FNEP coordinator. We had both the SNAP-Ed and the FNEP coordinator. But the curriculum that we used was just the one that is tailored to the SNAP-Ed audience, which is already in the SNAP-Ed toolkit. Yeah, so they create better health. So yeah, and oh, okay. So that, yeah, I hope I answered your question.
No, you did. I think there's hurdles. I think but they should be based on what you found and other research. It's really important that we address and culturally adapt our program in FNEP. I just think it's lacking. So it really points to that really great work that you did.
Yeah, and we hope someday that the Somali version we get to the NEPED toolkit too. So
I can
Great.
add. I can add if you allow or the time allow.
okay.
Is that okay?
Mm-hmm.
Okay.
Yes.
So we use SNAP at curriculum because was already kind of tailored for people who speak second language in their level, particularly were kind of catered a little bit refugee in general. So it was easy for us to use that one and also adapt it particularly to Somali way, because the food is still, though all refugee are the same issue, the same culture, some of them, but also each refugee, they have their unique culture. So that's why we use that one instead the FNEP when we use the SNAP ad, because it was already halfway done, and then we go from there. But we use the evaluation, the FNEP evaluation, because that is a validated tool. So that is why we have to
Right.
use the FNEP evaluation. So,
Right.
so that was the difference. We didn't use the FNEP curriculum. We got this one beginning because it was already other graduate student already started to do some work. So it was easy for us. And even some of the educators, they were using for the refugees. So thank you.
That's great. So you use the 30 question questionnaire.
Yes.
Yeah, that's great.
Yeah.
Good. Thank you.
So I see that we are running out of time. Thank you all so much for the wonderful questions. And of course, thank you, Dr. Atoloye, for your time. What would be the best way to reach you if further questions come up? I know you had your email address up. Is that your UConn email?
Yeah, you can email.
So I'm going to paste that and put that into the chat. So if anyone has any questions, they can feel free to reach out. Well, thank you again for joining us, and take care.
Yeah, thank you.